An aortic aneurysm is known as the silent killer because most people have no symptoms. A grant-funded project through OSF Innovation is working to improve the detection and monitoring of this potentially fatal condition.
By demonstrating how we can go from lab to clinic with this one project, it's rather a simple problem. Something we can talk about in the future is going to be how we solve this at scale and bring these to the patient on the forefront faster than we could through any other mechanism.
That's Dr. Matthew Bramlet, pediatric cardiologist and the director of the Advanced Imaging and Modeling Lab at OSF Innovation. And I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Aortic aneurysms are bulges or ballooning in the aorta, the body's main artery. They occur when the aorta's wall weakens, making it prone to rupture or dissection, which can prove fatal. Approximately 200,000 people in the United States are diagnosed with aortic aneurysms each year. Diagnosing aortic aneurysms can be challenging because they often develop without noticeable symptoms. A Jump Arches grant through OSF Innovation is working to more easily find and monitor aortic aneurysms. Joining me to talk about automatic aortic aneurysm analysis from medical imaging, that is a mouthful, is Dr. Matthew Bramlet, a pediatric cardiologist and the director of the Advanced Imaging and Modeling Lab at OSF Innovation. So, what was the genesis of this project as we look at it? I mean, aortic aneurysms are a thing, and often, as I said, they don't get caught early. Is that kind of where this all started?
Honestly, this is my job to detect these and to image them, and I thought that I could do it faster and better with computer.
That seems very simple. What is the biggest challenge with finding an aortic aneurysm? Because it's not like it's something obvious, and it can go run the gamuts of there's not a typical patient, is there?
No, the thing that, so in congenital heart disease, we deal with a lot of scenarios where there's been an operation in the past, or there's been a point in time where the aorta got a little extra blood flow and it resulted in enlargement of the aorta. And one of the things with congenital heart disease, and even into young adulthood, it's not so much how, well, let me back up. If the aorta gets too large, the wall loses some of its strength, and like a balloon, it can pop, which can be fatal. This is a big deal.
Yeah.
We have very strict guidelines on how big that measurement should be. And especially in younger adults or smaller adults, that measurement it's more important, the longitudinal, like how has it changed over the years, than it is a specific point in time, although that is also very important. And so this is what I do every day. I read these MRIs, CTs, MRIs. We prefer that for especially longitudinal cases because you don't want to irradiate someone all the time. And the trick is to have a measurement that is the same spot, same measurement as the one from 5 years ago. And especially in complex congenital heart disease, you can think about the aorta like a candy cane. These candy canes can be pretty...
Not just your typical candy cane. They go all over the place.
Hairpin turns, and there are a lot of variation. And so what I've got a few years under my belt now, but I'm pretty good about being able to know exactly where to measure it and have those measurements be reproducible over time. I take great pride in this. I mean, I want to be able to provide the decision makers and the surgeons with very accurate, reproducible results. That's where this came from, because it can be very difficult. And I reviewed the latest software in all of these, and there's not a software that does the MRI. I do this I measure most of these on a non-contrast MRI, and there's no software that deals with that. The top-of-the-line CT software can give me some measurements in some locations which is not hard, but the hard locations, it's not very good. It's not reliable, it's not reproducible. And so the work we've been doing in our lab led me towards this project.
So how will this ultimately change the detection and monitoring? Is it just making it easier to find it?
There are a couple things. Number one, in our lab, we've really honed in on this idea that if I can create a 3D model of the anatomy, that we're going to have an improved understanding of that anatomy. And so a major barrier to that is to automate the segmentation or automate the generation of the model. And I like to say our vision of the lab is that the patient enters the scanner on the left and their digital twin comes out on the right. And so when you hear that term digital twin thrown around quite a bit, but if you can imagine every organ in your body having an exact digital copy of it. So I've got the aorta, I've got the heart, I've got the lungs. Each one of those having its own digital version. The concept that I think is unique to our lab is we're not trying to take a CT or an MRI data set and use machine learning to automate the measurement. And that's what all the software is doing. It's like, how can I take this 2D image and measure it? What we're doing, and we've published on this, is we're generating that 3D model of the aorta. We're generating a 3D candy cane. Then we're measuring the model. So when we're performing our measurements, we have a 3D model, and it literally, like a candy cane, and we just have to use fancy math to create a program that goes around that candy cane and measures it and outputs that data. And the benefit of doing this, and this is everything we're doing in our lab. So again, we are generating digital twins. I think we have one of the largest, if not the largest, digital twin library in the U.S. And our whole concept is if I'm making the model first and then I am analyzing the model, it doesn't matter if I'm generating that model from an MRI, from an MRA, from a CT, or from any imaging modality. If I'm generating an exact replica of an organ, then I just need to apply all of my different analytic tools to those models. And that's really the aorta is our first. We have several projects on this idea, this concept, but the aorta is our first that we're moving from out of the lab into application.
So are there certain, diagnoses that are more prone to developing the aortic aneurysm? So is there a specific patient set that you're looking at that may be more challenging without this technology to get those measurements from?
There are definitely genetic conditions that can result in weakened tissues in the body, including the aorta. Marfan syndrome is number one, Loeys-Dietz, Ehlers-Danlos. There are other forms of congenital heart disease like bicuspid aortic valve or aortic valve disease that can result in sort of jets coming through the valve and there being weakening the valve, or there are all kinds of things that can are targets for this technology. But even in adults, there are acquired, different aortic valve disease, heart disease, smoking, other risk factors, hypertension, right, that can lead to these scenarios. The benefit of taking, and again, whenever I started doing this, I wasn't as good as I am today. And, I had training to do this, to get these reproducible measurements over time, but it really took years and years of expertise of doing this. I've done thousands of these to get it to the point where I can measure, patient A, and then 5 years come back and measure patient A and have those measurements be an accurate representation of what's occurred over the past 5 years. That is what we're trying to solve. And because it is a high level of expertise, think about, a lot of patients, they're having to come to this tertiary, quaternary care center to get that high level of expertise. If we can automate this, where we're generating a 3D model and then we're generating automated measurements, we're transferring the expertise that is in my mind that we use to develop this program to the public, to anyone that can use that. And in making that barrier of analysis much, much lower, it opens up many other opportunities. One of the things that we have 2 projects that we're moving forward within the hospital, which I'll get to that in a second. The first is what we call Z-scores, or standard deviation normative values. So like we have standard numbers for Marfan syndrome, but it's not really carved out too much into male, female. There are other conditions, Turner syndrome, Loeys-Dietz, all of the different tetralogy of flow, different congenital heart disease. Now, rather than spending hours and months of data collection to generate, here's a normative value for this specific type of, this cohort of patient, we are now going to literally click a button and get those numbers. And so now when I'm sitting in surgery conference, I don't have to go off of some random, here's a very generalized guideline. I can look at our own center's population, our own natural history study of very specific disease, male, female, body surface, indexed to a patient's size, because not everybody's built the same size, and really have a much improved understanding of the scenario so that we can make a better decision. While dissection, the aorta bursting, is fatal and terrible, the procedure to go in and correct it is also a very complex procedure with its own risks. And so we don't want to make these surgical decisions lightly. We need improved tools to make better decisions and to really know when to say, now is the time to perform a high-risk preventative surgery. Because it is definitely better than the other, but we want to be able to have this extend beyond the walls here.
Well, yeah, and you're talking with a younger population that you're describing. So, you want to improve life expectancy. This one ultimately really is all of the work you do is a patient focus, but this one, boy, seems like a very immediate, we can have a big impact on these young people.
One of the things that I've been very impressed with OSF, again, this is a combination of the OSF clinical entity, jump simulation engineering, sort of where the lab is, and we're performing a lot of this research, and U of I's College of Engineering. This is a collaborative effort amongst all of those. The thing I'm impressed with that a lot of other institutions struggle with is, how do we take something from a lab and move it into a clinical practice? And that is very difficult. If you can imagine, if I'm asking for, I need 1,000 studies for my, we need a large computational GPU-enabled server that is going to just crank through these patients and generate these results that we can then put into a paper that says, hey, here are new guidelines. That is a monumental task. OSF is one of the rare institutions where it's not, no, we can't do that, to, okay, let's figure this out. And that's where we're in that process right now.
And again, patients will benefit potentially across the country, right? Because again, the other beauty of this is you share this information and what you've learned, and others learn from you.
Yeah, and I'm improved understanding and quality of data, reproducibility of data is job number one. But I'll tell you, it takes me about 20 to 30 minutes to do this on every scan I do. With this, I just it takes me 30 seconds, I've got the data. And so I have cardiologists coming through my lab going, when can I have this?
Yeah.
And so, anything that's going to improve, I'm looking to improve effectiveness and efficiency across the board in all of these. And so if we are successful in demonstrating the reliability of these normative data across large populations, which I'm confident we will, and then we demonstrate that the clinical adoption of this tool saves time and improves results, we have both. We've checked boxes. This is it's the better mousetrap, right? And so that's what we're excited about. Not just the development of the technology, which we're done. We've already developed it. It's the deployment, and that's where having OSF Innovation integrated, and with the resources through the Arches Foundation, which is where this was funded, is just remarkable. I mean, and again, this is here in Peoria. We have resources people don't realize that other places can't even fathom.
You teased it a little bit talking about JUMP Arches. And again, I always have to read what that stands for because it is a mouthful. The JUMP, Applied Research for Community Health Through Engineering and Simulation. That's what Arches stands for. And this has been going for a number of years. What does that program mean for you, your work, all those around you? I mean, it's a game changer, isn't it?
It is the lifeblood of our lab, really. It is I think about $112 million endowment that an endowment gives off, let's say, about $4 million a year. And there is a U of I component and an OSF component. And the Arches in particular was designed so that you had to have a clinician, which in my case, I am that co-PI, and you have to have an engineering co-PI. And I found an incredible professor, Dr. Brad Sutton over in Champaign, who we've been working on many of these projects together. And it's, this started back in, 2015, 2016, something like that. And we've been, in this program every year, and I've seen the maturity of this program, and we are growing with it. And the work we're doing is, the Arches program is an incredible resource of like translational engineering research funding, where you take a clinician who says, hey, here's a problem, and the engineer goes, I've got a solution for that. And what we're avoiding engineers operating on their own, where they're solving a problem that's not really a problem, or you've got physicians, wanting to conduct research without an engineer say, well, you're going about it all wrong. This is a proven model, and this project is a great example of how it went from bench to now we're looking to deploy it to actually translate into real care.
I think the other cool thing about Arches is, you're one of many projects, this one that we're talking about, but there's every year people apply for it. What can we get? And there is a litany, and it covers everything. The ones that get approved, it's just amazing. And the amazing part, truly, at the end of the day, is the impact it can have on healthcare, on patient care, and across the spectrum is kind of the beauty of it, isn't it?
Yeah. When we started I started my whole foray from 100% clinical to, 80% research back in 2014 when we printed a heart for pre-surgical planning. And I was very fortunate. I had a few resources thrown my way, and I realized that not every idea was the best idea. But the lesson I took away from that was I need to be better about defining my problem and staying problem-centric and not going down. And that's a problem with a lot of research. It's like you just sort of go down these rabbit holes, and somebody says, well, I want this. But you have to always back up to say, what problem are you solving? And you stick to solving those problems. And I attribute a lot of that, and it's a business model, lean business model type mentality. I attribute to applying that to research that's kept us focused on solving actually real problems.
And learning from the failures along the way, too, because that's the other thing about research. Everything isn't going to work.
No, yeah, for sure.
Anything else we haven't touched on about the aortic aneurysm work that we need to cover?
I'm obviously very passionate about this. By demonstrating how we can go from lab to clinic with this one project, I have a list of other project that are all sitting and ready to make that leap as well. And this one is a very nice, it's rather a simple problem of that still doesn't exist. Like nobody has MRI autoseg for aortas. We have that. The software does not do the root well. Our software does the root well because we're 3D model centric. And something we can talk about in the future is going to be how we solve this at scale and explode this technology, not just aorta, but the 4D heart, we have stereo EEG visualizations. We have all of these, and bring these to the patient on the forefront faster than we could through any other mechanism.
And on that, Dr. Matthew Bramlet, thank you so much for the latest update on so many fascinating things going on in the lab. Appreciate you taking time. And thank you for joining us as well. Remember, you can catch every episode of OSF Healthcare Accelerated at osfhealthcare.org/accelerated.